Morning, everyone. So as Dr. Lee said, I'm going to talk about immunotherapy for prostate cancer today. So we'll start with an introduction, talk about immune editing, immune escape, immunotherapy in general, current state of immunotherapy and other genital urinary cancers, prostate cancer therapies with immune effects, and techniques to enhance immunotherapy. There are many forms of immunotherapy that have been successfully used in other cancers. There's immune checkpoint inhibition, and that's used in urothelial carcinoma, renal cell carcinoma, colorectal cancer, melanoma, lung cancer. There's T-cell redirection, which is new and has been pioneered in leukemia, and everyone's familiar with BCG and urothelial carcinoma. Now, the prostate has many qualities that lend it to treatment with immunotherapy. It's within a non-essential organ, and there's multiple novel antigens, PSA, PSMA, PAP, and PSCA. First, just want to start with a review. In 1909, Ehrlich suggested there was immune clearance of aberrant evolving tumor cells continually. This was supported by murine models with immune deficiencies in patients under significant immunosuppression, having significantly increased incidence of tumors and increased susceptibility to carcinogen-induced tumors. For immunoediting, there's three steps that are in continuum. There's elimination, where evolving tumor cells are successfully cleared by the innate and adaptive immune system. There's equilibrium, occurs when tumor cells are not completely cleared, but the numbers are controlled and the cells may go into senescence. And there's escape, when the tumor cells develop the ability to propagate unchecked by the immune system. For immune escape, this is selective pressure by the immune system, which can create tumor cells capable of evading the immune system or resisting lysis. It's a Darwinian stepwise accumulation of somatic mutations. This just kind of shows that clonal selection. This is for talking about different environments, but it's the same thing in terms of immune landscape and evading each one of those interactions. Now, in terms of prostate cancer specifically, there can be reduced immune recognition from defective or downregulation of HLA class 1. This can render T cells ineffective. Prostate cancer can render T cells ineffective by expression of fast ligand, inducing T cell apoptosis. There's increased resistance or survival from immunosuppressive cytokines, and there's been development of immunosuppressive tumor microenvironment as the cancer develops, possibly by increasing T regulatory cells within prostate cancer. So what have we done in just general urinary cancer? Bladder cancer, we have BCG, pembrolizumab, atezolizumab, nivolumab, avelumab, durvalumab, most of the checkpoint inhibitors. In kidney cancer, we have nivo-ipi, pembro with axitinib, and ongoing investigations of avelumab and axitinib. For penile cancer, we use topical imiquimod for localized disease, and for testes cancer, there hasn't been any trials showing any effectiveness. While within the prostate, we have vaccination, immune checkpoint inhibition, immune redirection, and immunomodulators. In terms of vaccinations, there's two main types. There's passive and active. Passive is the transference of immune effectors primed, already activated, to kill cancer cells developed ex vivo, and active is based on agents capable of generating activated T cells, and two types, there's cell-based and vector-based techniques. So the first to talk about is Sipuleucel-T. It's PAP-specific T cells which are generated ex vivo. There's a PAP GM-CSF fusion protein. It's incubated with autologous peripheral blood mononuclear cells and obtained by leukapheresis. The GM-CSF is used to activate APCs, which then in turn activate and induce replication of the PAP-specific immune T cells. 3 days after leukapheresis, or 48 hours after incubation, the cells are washed to remove the fusion protein. The cells are then shipped to the patient care site and infused. It's just, prostate acid phosphatase. It's an older, it's kind of like the old PSA essentially, in terms of an antigen. So you take the peripheral blood from the patient, harvest leukocytes, spin them down to get the monocytes, and then you use the GM-CSF PAP fusion protein incubated with them to activate the cells of interest that can respond to prostate cancer. Once that's cultured, those are then infused back into the patient. They can lead to activated antigen presenting cells like dendritic cells, which activate T cells and can lead to prostate cell lysis. So for Sipuleucel-T, it's administered as 3 doses every 2 weeks. Median overall survival benefit was 4.1 to 6.7 months, so that was in 3 phase 3 trials. There's a 38 to 50% increase in survival at 3 years. As I said, there's 3 phase 3 trials, and this led to FDA approval in 2010. Final trial impact is the one that had the largest impact. Kind of interesting it's named after. So this is the New England Journal publication, the last one that led to the FDA approval. Randomized controlled trial in asymptomatic metastatic CRPC patients, PSA greater than 5, castrate testosterone, and ECOG score 0 or 1, with expected survival greater than 6 months. It's a good population with metastatic prostate cancer. They excluded patients with ECOG scores greater than 1, visceral metastasis, pathologic long bone fractures, spinal cord compression, steroids, decreasing immune system. So it really was a fairly healthy population. Patients were stratified by Gleason score, number of bone metastasis, and bisphosphonate use. Bisphosphonates were allowed, you just can come off them within 28 days. This included 512 patients, 2-to-1 Sipuleucel-T versus placebo. Median survival was 4.1 months longer with treatment. Estimated probability of 36-month survival was 31.7% in the treatment arm and 23% in the placebo group. There was no difference in disease progression and minimal changes in PSA. PSA and in vitro indicators of immune activation and potency correlated with overall survival. This is the primary outcome, the overall survival curve, showing separation. So if we look at the AUA guidelines, this is for CRPC. If you look at metastatic CRPC at the top, I guess it didn't come out very well for everyone, but hopefully you can appreciate it. If we look here, metastatic CRPC patients, no previous chemotherapy, asymptomatic or minimally symptomatic. Sipuleucel-T is listed here, so it is in the guidelines for the US. Now, there's been low clinical uptake, possibly due to discordance between overall survival improvement and lack of PFS benefit and PSA response. There's a significant cost and effort involved in manufacturing this, and possible adverse effects of leukapheresis. Now, this is a real-world outcome of SipT treatment in PROCEED. It's a multi-center observational registry of 1,976 metastatic CRPC patients undergoing SipT treatment. This is a real-world population, including some minimally symptomatic patients, some with visceral metastasis, and introduction of novel life-prolonging therapies, enzalutamide, abiraterone, and patients with worse ECOG scores. The median OS was 30.7 months, and this has improved over the IMPACT study, and it's thought due to lower average PSA within the group and novel therapies, once again, enzalutamide, abiraterone. SipT was shown to be safe and well tolerated in the real-world setting, and there was improved survival in patients who had a PSA of less than 5.27, and once again, if they had immune activation and with product potency. So cumulative APC activation, APC counts, and total nucleated cell counts in the product, showing that it was a good product ready for infusion and stimulate the immune system. There was some concerns regarding cerebral vascular accidents in SipT. This was observed at 2.8%, and less than 1% of the population experienced a grade 3 to 5 CVA, and this rate was equal to the rate of CVA within the SEER Medicare database. So it was thought that though there's a high number of events, it's the same. It's just an older population with comorbidities. Now this is PROSVAC. PROSVAC is an active viral vector-based immunotherapy containing PSA as tumor antigen used to stimulate T-cell response. It uses a prime boost regimen using 2 different live pox viral-based vectors. There's POSVAC-F and POSVAC-V, both containing transgenes for human PSA and 3 co-stimulatory molecules for T cells, which are synergistic when added to the pox viral system. There was a signal for overall survival in the phase 2 study, which prompted this trial. There was increased overall survival, 25.1 months versus 16.6 months, but no PFS, which was the primary endpoint. So this is the phase 3 study, randomized controlled trial, double-blind, placebo-controlled, 1:1:1. There was the active treatment arm, PROSVAC plus GM-CSF, PROSVAC plus placebo, or vaccine placebo plus the GM-CSF in 1,297 asymptomatic or minimally symptomatic patients with metastatic prostate cancer. And they were chemo-naive in the metastatic setting, meaning they could have had adjuvant therapy after. There was castrate testosterone with current GnRH agonist or antagonist, unless surgically the patient was castrate. There was a 6-week washout period for anti-androgens and medications for bone health that was permitted. Now there's priming immunization at week 1 with post-vac V, followed by 6 boosting immunizations of post-vac F. Additionally, GM-CSF injection was within 5 millimeters of the original site on the day of immunization and within 3 consecutive days. This is the survival curve, a little bit dismal, no separation, and it was recommended to be ended early because they weren't going to reach their primary endpoint of overall survival benefit. Moving to another vaccination, GVAX. GVAX is a GM-CSF secreting tumor cell vaccine generated in PC3 and LNCAP tumor lines. Cells receive a dose of radiation before infusion to inhibit replication. They're ensured to be secreting GM-CSF based on ELISA and immune responsive patient by assessment of LNCAP and PC3 antibodies to ensure that the patient did mount an immune response. And there was peripheral instillation conducted after prostatectomy. So this was in the adjuvant setting. In phase 1 and phase 2 studies, GVAX demonstrated significant decrease in PSA velocity. This was in a post-prostatectomy relapse, less than 4 years after the prostatectomy, and with a PSA greater than 1. Patients were excluded if they had previous radiation, hormonal therapy, or chemotherapy. There was significant PSA velocity decrease in 75% of patients at 20 weeks. This led to 2 phase 3 trials, which were terminated early based on futility assessments. So was the VITAL-1 and VITAL-2 trials. Randomized studies in both chemotherapy-naive patients or in conjunction with chemotherapy were conducted. And actually in the combination of chemotherapy with GVAX, there was increased mortality observed, kind of a cautionary tale. If we keep looking at vaccinations, there's DCVac, PCA. It's an autologous dendrite cell vaccine derived from peripheral blood in combination with low-dose oral cyclophosphamide. That's used to decrease the T regulatory cells, which are inhibitory, and a toll-like receptor agonist to promote immune response. Phase 3 trial variable is in combination with chemotherapy, still ongoing, so no results from that. There's Prostate. It's a viral vector transfer of herpes simplex thymidine kinase to tumor cells. In phase 1 and 2 trial, patients received this treatment prior to prostatectomy, and there's shown to be a transient PSA rise followed by a drop. Phase 3 is currently recruiting localized intermediate high-risk prostate cancer patients prior to radiation therapy for this injection. I'd like to move and talk about chimeric antigen receptor T cells. So these are cells that you change their effector antibodies, so you change what they respond to, and they're the patient's own immune cells. So you collect the patient's blood, isolate the T cells, and then you transfect the chimeric antigen receptor into those T cells. You activate them, multiply them, and inject them back in, and they're showing some improved response. In trials for CAR T cells, they're directed towards the prostate stem cell antigen, and we're able to activate and delay tumor growth. This has also been shown to prolong overall survival in mouse, though human trials are in development right now and will be ongoing in the City of Hope in Philadelphia. Well, as Dr. Gleave said, you can't do a talk on immunotherapy without talking about checkpoint inhibitors. There's been many approved, PD-1, PD-L1, CTLA-4, and there's also many other checkpoints for immune regulation. So this is a study looking at ipilimumab, CTLA-4 inhibitor, after radiotherapy in patients with metastatic CRPC who had progressed after docetaxel. Randomized controlled trial, 1-to-1 to receive bone-directed radiation therapy, and then possibly ipilimumab after. At 11.2 months in the treatment arm versus 10 months in the control arm. That was the overall survival. This wasn't deemed significant, so there's no improvement in overall survival, but it appeared that the hazard ratio for overall survival decreased over time, saying that maybe there was improvement, but there wasn't long enough follow-up initially. And a post-hoc analysis showed that favorable patients had improved in survival of 22.7 months versus 15.8 months in the treatment arm that just received radiation alone. Favorable is defined by ALP less than 1.5 times the upper limit of normal, hemoglobin of 110 or more, and no visceral metastasis. Then there was a study looking at ipilimumab once again, but this time in chemotherapy-naive patients who were symptomatic. Phase 3, double-blind, 2-to-1, treatment versus placebo. There was no improvement in overall survival, but there was improvement in PFS, 5.6 months in the ipilimumab arm versus 3.8 months in the placebo arm. Not great response. Moving on to pembrolizumab for advanced prostate cancer. This was presented at ESMO, I think in ASCO, 2018. Phase 1 trial. No treatment-related discontinuations or deaths associated with pembrolizumab. This was a heavily pretreated cohort. I think 91% had been through chemotherapy. Most had been through second-generation AR antagonists. And there was 14.3% expression of PD-1. Now, 23 patients with CRPC were included. 23 patients with CRPC showed a 17.4% overall survival rate improvement, and 4 patients had a partial response. The responses were durable, lasting greater than a year in most patients. The median response was 59 weeks. And this is what we've seen in other trials with immunotherapy. Patients who have response can have a durable response. This was shown at ASCO 2018. This is Keynote 199. It's with pembrolizumab. This was a pretty complex study, including multiple arms. So cohort 1 was PD-L1 positive patients who had measurable disease on CT scan. Cohort 2 was PD-L1 negative with measurable disease on CT scan. Cohort 3, they had bone mets but no measurable disease on CT scan, and they could have any PD-L1 status. And cohort 4 and 5, they were in combination with enzalutamide, and they could have metastasis or no metastasis based on CT scan. Overall disease control rate was 11%, showing some response, with a PSA decline of greater than 50%. In cohort 1, that's the PD-L1 positive group, the overall response rate was 6%, and cohort 2 was only 3%. Cohort 2 was the PD-L1 negative cohort. In cohort 1, 2 patients had a complete response. 2 patients, and that was 2%, had a complete response. 5 patients, or 4%, had a partial response, and 22 patients, or 17%, of patients had stable disease. Similar results were seen in cohort 2, and of note, more patients responded without BRCA1 and 2 mutations, ATM, or other DNA damage repair gene mutations. Normally, these are populations that we would think would have a better response. There was no improved response in this study. So moving on to Keynote 046, this is a phase 1 trial of combination of pembrolizumab with an attenuated Listeria monocytogenes as the antigen-derived vector. So we're looking at combinations now of checkpoint inhibitors with checkpoint inhibitors or other immune agents. There's only preliminary results and showed 43% of patients receiving combination therapy had a decrease in PSA. 22% had a PSA decline of greater than 50%. Only 14% of the monotherapy patients just receiving the pembrolizumab had a decline in PSA of greater than 50%. Checkmate 650 is combination of nivolumab and ipilimumab in metastatic CRPC patients with progression on second-generation antiandrogens. So they've been through the abiraterone or enzalutamide. Overall response rate was 26% in chemo-naive patients and 11% post-chemotherapy. The overall response rate in patients with PD-L1 greater than 1%, the overall response rate was higher in patients with PD-L1 greater than 1%, DNA damage repair defects, homologous recombination deficiencies, or high tumor mutational burdens. Now, this was just presented at ESMO this year, and we had a couple people involved, Dr. Colemannsberger, Alex Wyatt. It's a multi-center randomized phase 2 trial, including 52 patients. ECOG score 0 or 1, received prior second-generation antiandrogens and no more than 1 taxane. They were treated with durvalumab plus or minus tremelimumab. Patients were treated alone with durvalumab, 13 patients. There was no response seen, but when in combination, 6 patients had a complete response and 16 patients had an objective response. Of the 2 patients who were identified with a high microsatellite instability, 1 patient responded. Now, I guess that kind of transitions us nicely into checkpoint inhibitors and microsatellite instability. For checkpoint inhibitors, which we've obviously kind of been going through, there's FDA approval for use of PD-L1 such as pembrolizumab, in MS-high patients for any tumor location. So you could use it in prostate cancer even though it's not explicitly allowed outside a trial. There are numerous factors that may improve the efficacy of checkpoint inhibitors: tumor mutational burden, mutations in DNA damage repair genes, immune cell composition and density in combination with spatial orientation within the tumor. So if they're in the center of the tumor or at the invasive margins, those are thought to be more responsive, and that classifies the tumor as hot, and non-T cell inflamed would be cold, and the expression of immune checkpoint proteins. Now, generally, there's low somatic mutational burden and diminished neoadjuvant expression in prostate cancer. It's approximately 0.9 per megabase, which is 10 times less than melanoma. And melanoma is kind of the prototypic for checkpoint inhibitors. It responds quite well. And this results in fewer antigen-presenting cells, which cross-prime T-infiltrating lymphocytes. Prostate cancer also has aberrations in PTEN in approximately 55%, which has been shown to decrease effectiveness of PD-1 immunotherapy. Prostate cancer also has mutations in interferon 1 signaling, and this is important for PD-1 immunotherapy. This has been shown in melanoma. And aberrations in PTEN also affect P1 signaling, interferon 1 signaling. Now, after treatment with anti-CTLA-4, ipilimumab, there's increased expression of inhibitory molecule VISTA. So I just wanted to show that. So I hadn't come across VISTA before, but VISTA is a V-domain immunoglobulin suppressor of T-cell activation. It's kind of like another checkpoint inhibitor. It's an immune checkpoint receptor expressed in T-infiltrating lymphocytes and myeloid cells. It leads to suppression of T-cell activation, proliferation, and cytokine production. The extracellular domain is similar to PD-L1, but it interferes with a different subset of lymphocytes. So it's another spot where the immune system can get inhibited. Some studies in prostate cancer showing apparently immune active, so hot tumors, actually have worse outcomes. It's unsure why. There's debate regarding the T-infiltrating lymphocyte state of energy, exhaustion, or senescence, possibly impaired due to secreted or cellular immunosuppressive agents, and elevated population of T regulatory cells within prostate cancer. It may be affected by hormones, genetic alterations, or selective alterations. It's just a diagram, once again, showing how prostate cancer can have an inhibitory microenvironment. So you can have dysfunctional T cells from chronic interferon 1 pathway activation, decreased inflammatory chemotaxis. There's not a lot of antigens, so low mutational burden. There's intact DNA damage repair processes most of the time. As I mentioned earlier, there can be a loss of MHC class 1 and increased regulatory cells, the FOXP3 Tregs, that can inhibit the immune system. I want to discuss a promising case. So this was a 49-year-old male with Gleason 4+5 prostate cancer, PSA of 25 with de novo clinical nodal metastasis. Within 1.5 years of a prostatectomy, the patient progressed to CRPC and clinically progressed on abiraterone and docetaxel, which was ceased due to poor tolerability. The patient underwent germline genomic testing, which showed complete loss of MSH2 and high microsatellite instability. The patient was started on pembrolizumab. As we said, you can use it in any, well, the FDA has approved it in any patient that has MSI high mutations. After 2 weeks of treatment, the PSA went from 15 to undetectable, and the patient finished 12 treatments every 3 weeks. Over 1 year later, the patient continues to have a complete response. So once again, there does appear to be patients with prostate cancer who are better selected for these treatments. The incidence of microsatellite instability high may be approximately 5% in CRPC. There's a higher incidence of MSH2, which is that microsatellite instability mutation, or one of them, in Gleason greater or equal 9, and prostate cancer with neuroendocrine features at approximately 7%. Germline mutations in Lynch syndrome associated genes are only identified in approximately 0.5% of patients with CRPC. Looking at microsatellite instability, this is a tumor molecular phenotype resulting from genomic hypermutability. Microsatellite instability is a molecular diagnosis examined from PCR and usually need to have mutations in 5 to 7 informative microsatellite markers. This is MSI PCR. There's other methods that are being developed to pick up microsatellite instability, such as massive parallel DNA sequencing technologies that can pick up more of them across more mutational sites. And this may occur due to impairment in DNA mismatch repair from inactivation or epigenetic silencing of the pathway. Now, in a small retrospective series of 11 patients with MSI-high tumors who were treated with pembrolizumab, 6 patients had a 50% response in PSA. So once again, as we would expect, even prostate cancer with these mutations does respond better, even with the inhibitory tumor microenvironment of prostate cancer. In another study of 4 patients with DNA mismatch repair defects treated with nivolumab or pembrolizumab, 2 patients had a 50% decrease in PSA, and 3 patients had radiographic response to treatment. So this is an ongoing trial looking at checkpoint inhibition in MSI-high patients. It's the Perseus-1. It's a phase 2 trial of pembrolizumab in patients with metastatic CRPC after progression on previous treatment of CRPC. They must have a high mutational burden or a DNA damage repair defect that increases the mutational load. The primary endpoint will be overall survival, PSA decline of 50%, or decrease in circulating tumor cells. So, as we've talked about, monotherapy with checkpoint inhibitors has had poor results. Checkpoint inhibitors appear to be more effective when in combination, and microsatellite instability high patients have shown improved responses. I'd like to move on to CDK12 mutations. These are mutations that can lead to inactivation of the kinase domain of CDK12. Biallelic mutations are only seen in 5.7 to 6.9% of patients with metastatic CRPC, and only about 1% of patients with localized prostate cancer. There's low tolerability for germline mutations, and these are rarely found, and this leads to a specific translational phenotype. So if we look here, if you have a biallelic mutation in CDK12, it leads to genomic instabilities and lots of these extensive tandem duplications. This leads to increase in neoantigen and increased antigen for T cells to identify and respond to. So this is quite similar to the microsatellite instability high patients. In patients treated with checkpoint inhibitors, patients had a decline of PSA and radiographic response in 50%. There are ongoing multi-center study looking at checkpoint inhibitors in patients with CDK12 mutations. So what's the point? There's many ways that tumors can develop increased neoantigens for immune recognition. I think we need to identify these opportunities, figure out how to target them, and personalize treatment to improve the response. As we know, these aren't cheap drugs. So I'd like to talk about bispecific antibodies. So these are antibodies that can recognize 2 different domains. So in purple you have one antibody recognition, and then in green you have another. So what this can do is help bind 2 different cell types. So if the purple cell is a tumor cell, and if the brown cell is a T cell, you're bringing those in close proximity and giving them an opportunity to interact and activate the T cell. There's ongoing development in trials looking at these bispecific antibodies targeting CD3, which is the T cell receptor, and PSMA. There's been successful treatment in human leukemia patients, and there's approved treatment protocols. And we're actually starting a trial here, or involved in the trial. Kim Chi is. In non-human primate models, PSMA and CD3, bispecific antibodies, were able to recruit T cells, activate them, and lead to tumor lysis. And then there's immunomodulation. Tasquinimod binds histone deacetylase. It may cause reduction in stress-mediated hypoxia signaling and angiogenesis initiation. It blocks a key role in the function of regulatory myeloid cells, decreases the immunosuppressive microenvironment and angiogenesis in tumors. There's been increase in PFS, but no increase in OS in a phase 3 study. So I'd like to next move on to the immune effects of prostate cancer therapies. The effects of local treatment for prostate cancer may act synergistically or may improve the immune response to metastatic prostate cancer. Probably the classic one that people may be familiar with is the abscopal effect for radiation, where radiation at local sites leads to reduction in distant metastatic burden. It's a rare event. Radiation causes DNA damage, leading to apoptosis and cell necrosis. This releases antigens for T cell recognition and can lead to systemic response. This may be related to both dose and delivery schedules of radiation therapy. Also, radium-223 has been found to have immunomodulatory effects through enhanced lysis by cytotoxic T cells. It can cause the expansion of peripheral PD-1 positive T cells and exhaustion apoptosis of PD-1 positive CD8 T cells. So this is a case in cryotherapy. It's from the 1970s. The patient who had metastatic prostate cancer was also in retention, had cryotherapy for treatment of retention, and actually had two patients had symptomatic improvement in bony metastasis, showing that there may be a response systemically after local treatment with cryotherapy. Cryotherapy offers the benefits of local destruction of tumors. The freeze, thaw, and retreatment can give possible systemic response as the immune system is exposed to apoptotic factors. This freeze-thaw cycle also causes local coagulant necrosis, hemosiderin deposition, fibrosis. There's a couple thoughts on how it works, but it's very similar to before. You have the treated region showing necrosis. You have tumor cell debris that gets picked up by immune cells and then presented to T cells, possibly leading to antibody production and lysis of tumor cells. Cryotherapy may also decrease the number of regulatory T cells within the peripheral blood, though it's unclear if these are actually more activated, so more potent immune cells. There's a study that looked at ipilimumab in mice, and so what they did is they had mice who were treated with cryotherapy and ipilimumab. The cryotherapy was used to treat a primary tumor, but the mouse was also given a secondary tumor. And with the combination of cryotherapy and ipilimumab, there was a 44% reduction in the second tumor, while 100% of the patients who were just treated with the ipilimumab had progression of their second tumor. There was a 10 times increase in CD8 T lymphocytes in the second tumor with the combination of cryotherapy and ipilimumab in comparison to control mice. And there was a 4 and 8-fold increase in CD4 positive, FOXP3 negative. So those wouldn't be regulatory cells; those would be active effector cells in the cryotherapy group, and the ipilimumab treated a lone arm, so twice as many with combination. Now, androgen deprivation therapy it induces prostate cancer cell apoptosis, and early after treatment, there may be an inflammatory response within tumors. And this inflammatory response is associated with T-infiltrating lymphocytes, and it's theorized that this is a possible time to add immunotherapy when you have a little more of a hot microenvironment. So in conclusion, immunotherapy is becoming a key player in the treatment of many urologic cancers. Prostate cancer immunotherapy is making strides and is currently included in the AUA guidelines for treatment of CRPC. Checkpoint inhibitors show promise in patients with increased neoadjuvant presentation, and CAR T cells and bispecific antibodies are showing promise, and trial results will be eagerly anticipated. I'd like to thank Dr. Black, Dr. White, and Dr. Chi.